Points. Uh, so today, presenting a case of she's a 25-year-old female. She is a homemaker from Chamoli district of Uttarakhand. She presented with the chief complaints of recurrent episodes of bloody vomiting and black colored stool since 15 years, and also complaints of lump in the left upper abdomen since 1 year. History of presenting illness. She was apparently normal 15 years back, and then she started to develop recurrent episodes of bloody vomiting. The first episode of vomiting started at the age of 10 years and containing fresh blood with the clots, and it was for 5 episodes over 3 days, and a total amount of approximately 500 to 600 ml, and associated with passing of blacky tarry stools, and was associated with dizziness, for which she was taken to local hospital. There she was treated with IV fluids and blood transfusion. She also underwent endoscopic intervention for the same, followed which bleeding episodes were subsided. Since then, she gave history of recurrent attacks of similar bleeding episodes once in every 2 to 3 years till next 10 years, that is till 2020. And every episode, she was hospitalized and she was managed with endoscopic intervention. The last episode of bleed was in September 2024, that is 7 months back, which was presented with the melena associated with generalized weakness. She was hospitalized at the local hospital, and again she was received 2 units of blood transfusion and underwent endoscopic intervention. And she was discharged, and she was also advised to go to higher center for surgical management. She also gave history of easy fatigability and palpitation. There is no history of gum bleed, epistaxis, or bruise after trivial trauma. There is no history of fever or jaundice. No abdominal distension, leg swellings, or the altered sensorium. And there is no history suggestive of growth retardation. She also noticed a lump in the left upper abdomen since 1 year, which was gradually increasing in size and associated with dragging sensation and heaviness. And there is no history of epigastric pain or intake of analgesics. Into menstrual history, she attained menarche at the age of 13 years. Her menstruation was regular, but since last 4 months, she had history of excessive menstruation, that is, each cycle lasting for 24 days, at the flow of 7 days. Personal history, she is vegetarian by diet. There is no history of any addiction. No, she has studied till 10th standard with an average marks, and there is no sleep pattern, normal sleep pattern with normal bowel and bladder habits. The past history, past history, she gave past history of pneumonia in the childhood. However, there is no history of any diarrhea or dehydration in the childhood, and there is no other significant medical illness in the past, and no other previous surgeries in the past. And the drug history, she is on propranolol 20 mg twice daily since past 5 years. To summarize my history, sir, she is a 25-year-old female with history of recurrent hematemesis and melena since past 15 years. The last episode was 7 months back, which was managed by blood transfusion and endoscopic intervention. And with the left upper abdomen fullness and dragging sensation since 1 year, associated with menorrhagia and easy fatigability and weakness on non-selective beta blocker since 5 years. Menorrhagia since last 4 months. And there is no history of fever, jaundice, altered sensorium, abdominal distension, that is stigmata of liver failures absent. Uh, with this, my provisional diagnosis would be, sir, portal hypertension, most likely extrahepatic portal hypertension or non-cirrhotic uh, fibrosis.
Let's start from the beginning.
Yes, sir.
Morning, morning. So, as soon as you have these presenting complaints, what comes to your mind?
Uh, So she is having upper GI bleed associated with splenomegaly, sir, most probably.
Yeah, so
So
that's the
portal
interpretation. What do
hypertension.
you think? What do you make out of it?
Yes, sir. Young female with portal hypertension with the mass uh,
Yeah, the onset is at 10 years of age,
yes, sir.
isn't it? So you should say that a 10-year-old child who is now 25 years and she's having recurrent episodes of upper GI bleed with a lump in the left upper abdomen, probably splenomegaly. So this is portal hypertension. And portal hypertension starting at 10 years of age, what would be your diagnosis?
Most likely it would be either non-cirrhotic portal hypertension or it can be cirrhotic hypertension also, sir.
I don't think in a child with portal hypertension you should make a diagnosis of cirrhosis. The diagnosis should be extrahepatic portal venous obstruction. It may turn out to be cirrhosis. That's a different thing altogether. But the clinical diagnosis in a child who's presenting with upper GI bleed and splenomegaly, although at that time she didn't have splenomegaly, but still the commonest cause of upper GI bleed in a child would be portal hypertension, and the cause would be extrahepatic. And the cause would be extrahepatic portal venous obstruction. Okay, so when it comes to clinical diagnosis, you should make only the most probable diagnosis. And if the onset was, say, 5 years ago or even 10 years ago, adolescent or young adult, then you could have brought in non cirrhotic portal fibrosis. Next.
The history, sir, the first episode started at age of
So,
five
what
years.
does this history indicate? The second paragraph.
Uh, it indicates, sir, there is a large amount of bleed,
Yeah, so
massive bleed.
presence of clots, presence of symptoms of acute blood loss like dizziness, need for blood transfusion, all these indicate that it is a massive bleed.
Massive bleed.
Also, for how many days the melena continues, that also indicates the amount of bleeding. The number of stools the patient passes every day and the number of days for which melena continues, all this indicates the severity of bleed. So the history indicates that it was a massive bleed. Next. Now, sorry, in this only you say that she underwent endoscopy and the bleed controlled. And go to the next slide
Yes, sir.
now. From your history, it is not clear. Was she put on a regular endoscopic management protocol, or is it only SOS that whenever she has a bleed, they do an endoscopy and
Yes, sir.
control the bleed? That is not coming out from your history.
She was on whenever she had a bleed, she was not on regular endoscopic
So you have
follow-ups.
to mention that because see, if a patient has upper GI bleed, it is portal hypertension, it is variceal bleed. Patient goes to a hospital, they do an endoscopy, they do something to control the bleeding. It is expected that the patient will be put on an endoscopic management protocol. If it is not done, it has to come out in your history. Okay. Next. Now this. You asked about gum bleeding, epistaxis, bruise. Agreed. Yet you are looking at thrombocytopenia. Why did you ask
Yes, sir.
about history of fever or jaundice?
Sir, to rule out, sir, jaundice, either probability because of hemolysis, hemolytic anemia with associated with splenomegaly, or because of decompensation of the liver disease, sir, if if there, and also secondary to obstructive jaundice, that is cholangiopathy.
Yeah, so if we are thinking of EHPVO, then there are two possible causes. One, as you rightly said, hemolysis, and second is a portal biliopathy or portal cavernous cholangiopathy, which is causing biliary obstruction. So jaundice should come first. You are looking for jaundice. As a consequence of that, if it is obstructive jaundice, you are also looking for cholangitis. So it should be no history of jaundice and no history of fever with chills and rigors. Anything else for which fever could be important?
Uh,
Suppose there is no history of jaundice, but still could she be having fever?
yes, sir. History of recurrent fever indicates leukocytopenia, sir, associated with recurrent
So that
infections.
history should come as a separate, that she doesn't have recurrent episodes of fever. With what are the common sites where infection can occur in patients with leukopenia?
Sore throat, that is pharyngitis, sir, and uh,
So it's mainly
and
upper
chest in
respiratory, lower
respiratory.
respiratory, and urinary tract infection. So if you want to convey to the examiner that you are asking for symptoms of leukopenia or neutropenia, then that should come as a separate sentence. Okay. Now she has noticed this lump for 1 year. Is this the usual story?
No, sir, it will be there since years, sir. Long history will be there, which may be gradually progressing.
So you should say that usually the patients will notice spleen when they started bleeding. It is very unusual that she has been bleeding for almost 10 years and she has noticed this lump now. It may be that she didn't notice it, but that is not the usual story. Usually both the things will come together. And in fact, the size of the spleen or the size of the lump which the patient is feeling, an intelligent patient may even report that after a bleed,
Yes, sir.
the
The,
spleen may regress in size and then it comes back to its original size after a few days or a few weeks. What are the other symptoms? You have said dragging sensation. What other symptoms these patients who have large spleen, massive spleen, they can have?
um, heaviness, sir, and left abdominal fullness and early satiety because
Yeah,
of
so
compressive symptom.
you should mention all those symptoms. Whatever is possible, you should mention. Exam In the exam, negative history and negative examination is one way to preempt a question from the examiner, that what are the symptoms. If you already mention those symptoms, then the examiner knows that you know the symptoms of splenomegaly, because it is also important later on when you are going to decide the management. Because suppose the patient's bleed has been controlled by endoscopy, still, the splenomegaly and hypersplenism may become an indication for surgical intervention. And that is the time when you would like to know, or the examiner would like to know, how symptomatic the spleen is. So you have to describe the symptoms in more detail here rather than just saying dragging sensation. Can these patients have acute episodes of pain in the left upper abdomen?
Possible, sir. Whenever if there is a splenic infarct,
Yes.
uh,
So that
it,
again should come. That splenic infarct, it can cause acute episode of pain, which usually settles on its own. Okay. Next,
yeah,
anything else
this
in the menstrual history you should have mentioned?
uh,
You said
passage
that
of
she's having
clots,
excessive menstruation.
passage of clots.
Yeah, so not only the duration, the amount of bleeding, and these days, most young women will be using pads. So you can ask her how many pads she used to use earlier and how many pads per day she has to use now. Presence of clots again indicates a large amount of bleeding, and of course the duration, which you have already mentioned. So again, in the other history also, if there is an abnormality, you have to describe it in more details to give a complete picture. Next, this pneumonia in
Uh,
childhood, does it have any importance? Do you want to know anything more?
uh, no, sir. Childhood infection, especially in the infancy, if there is a diarrhea, would indicate.
So
abdominal infection. Yes, sir.
for a lay person, childhood is childhood, but we know that childhood is in neonatal infancy and then later on. So suppose she had a pneumonia in the neonatal period or early infancy, and at that time the umbilical vein was catheterized because nobody was getting an IV access anywhere else. Then does it become important?
Yes, sir.
It becomes important. So you
Yes,
should
sir.
have asked at what age did you have pneumonia. If it was very early in the neonatal period, then the best person to ask would be the mother. That was a cannula put somewhere around the umbilicus.
Yes, sir.
Okay, so umbilical sepsis and umbilical vein catheterization, these are supposed to be two predisposing risk factors for EHPVO. And you, especially when the patient says that I had pneumonia in childhood, you have to go into more details of this. Okay, next.
Yes,
So
summary,
uh,
sir.
the differential diagnosis, I think as I mentioned earlier, if a child aged 10 years starts having upper GI bleed, and she also says that there is a lump in the left upper abdomen, the diagnosis first you have rightly said it is portal hypertension, and then in this case your only clinical diagnosis based on history should be EHPVO. NCPF usually doesn't begin at the age of 10 years. NCPF is a difficult clinical diagnosis to make because it can look like EHPV or it can look like compensated cirrhosis. And CLD, to make a diagnosis of CLD in a child who doesn't have any features of decompensation, is not correct. You should not make a diagnosis of CLD. If there was a feature of decompensation,
Become-
then you could have said cirrhosis can occur in childhood also. It can be the cause of portal hypertension in a child also. But clinical diagnosis should remain EHPVO unless there is a strong indicator, which would be in the form of decompensation, either ascites or encephalopathy during an episode of bleed. Uh, then only you should say that it is cirrhosis. So, based on the clinical history in this patient, the diagnosis should be portal hypertension, extrahepatic portal venous obstruction. Okay.
yes,
If the examiner says, can it be cirrhosis or CLD? You should say, yes, it is possible. It can be compensated cirrhosis, but cirrhosis is not a common cause of portal hypertension in children. It is an uncommon or a rare cause, which I would not like to make a clinical diagnosis.
yes.
Okay.
That's it. That's- Coming to general physical examination, she is conscious, cooperative, oriented time, place, and person. She had height of 150 centimeter with BMI of 17.3. And vitally, she was pulse rate of 75, BP of 90 by 70 with a respiratory rate of 16. She was afebrile. And on examination, she had a pallor. There was no cyanosis, clubbing, icterus, or lymphadenopathy, no supraclavicular lymph node, no signs of liver cell failure.
Why did you specifically mention left supraclavicular or supraclavicular lymph node? Is it important here? Is it relevant here?
No, sir.
It is not. So
Not
don't
definitely.
see at this level your presentation is not of that an MBBS student that you have to mention everything. We expect you to mention only important and relevant. If you had said no generalized lymphadenopathy, that is acceptable, but don't mention supraclavicular node. Supraclavicular node has a specific connotation, has a specific meaning.
Abdominal examination on inspection, there was a
Oh,
fullness
sorry,
in the.
sorry, sorry. Go back
Yes, sir.
again.
Yes, sir.
Her height is 150 centimeter,
Yes, sir.
because earlier you said that there is no growth retardation.
Uh, but our family members are similar short stages. So
I don't know, for a 25-year-old female, whether this is less than even 5 feet, 150 centimeter. Will that be considered as a normal height, or will she be considered? Because growth retardation is reflected only in height, it is not reflected in weight. Many students make a wrong statement that BMI is low or normal or high. BMI has nothing to do with growth. BMI is an indicator of nutrition. Growth retardation is height for age. So you have to check if she has any siblings, whether she's or her younger siblings are taller than her. At this age, of course, it doesn't matter younger or older. Also, you can ask that when she was going to the school or college, what was her height related to her classmates. That is the best indicator in the history to say whether there is growth retardation. Hmm.
On abdomen examination, on inspection, there was a fullness in the left upper quadrant of the abdomen. Umbilicus was central and inverted, and there was no dilated veins, scar, pulsations, or peristalsis seen. There's no renal angle fullness. On
Where were you
palpation,
looking? Where were you looking for dilated veins?
periumbilical dilated veins.
That's all.
Uh,
In any patient with portal hypertension, may not be in this case. In any patient with portal hypertension, where do you look for dilated veins? Any other place where dilated veins can be present and patient is having portal hypertension? What about post-hepatic causes of portal hypertension?
yes, sir. For in a Budd-Chiari syndrome, there can be dilated veins in the flanks also, sir.
Yeah, so if there is IVC obstruction, which is causing Budd-Chiari and then portal hypertension and then CLD, you could have dilated veins in the flanks. Whereas in extrahepatic portal venous obstruction or in cirrhosis, you will have periumbilical. Okay.
Yes. On palpation, abdomen was soft, not tender, and there was a lump in the left hypochondrium extending till umbilical region, 12 cross 8 centimeter approx, with smooth surface, not tender, firm, reaching up to the umbilicus, and finger could not be insinuated between the costal margin, and there was a notch present, and with moves with the respiration, which is suggestive of a large spleen, there is splenomegaly,
Yeah,
and there
good
is no
description. Good description of a spleen. Only thing you could have added that when it moves with respiration, it doesn't move vertically downwards. It moves obliquely towards the right iliac fossa. That is the direction of enlargement of the spleen. So, does this examination finding fit in with your history? Because you said she noticed this lump only 1 year ago.
1 year.
And here we
Yes,
have
sir.
a spleen which is
Large.
reaching almost up to the umbilicus. So this will classify as massive splenomegaly.
Yes, sir.
So it's
She would
very
have
unlikely. It's very
unlikely.
unlikely that this spleen was not there before 1 year because it is unusual that there was no splenomegaly earlier and now you have a massive splenomegaly. Most probably she did not notice it. That is what you should say. Because when you have a finding on examination which doesn't fit in with history, obviously your examination finding is more objective, more correct rather than the patient's history.
On percussion, liver span was 12 centimeter in the mid-clavicular line. There was no ascites. On auscultation, there was normal bowel sound heard. On rectal examination and proctoscopy, there was rectal mucosa was normal, and there's a finger stain, fish stained with yellow colored stool.
Is the liver
And
span
systemic
normal? Does she have
liver
a
span
shrunken
was
liver? What is the
uh,
normal liver span?
there are 14 to 15 centimeters.
So is 12 centimeter normal?
It's reduced.
For her, it is normal. She's only 150 centimeter in height. The 14 centimeter liver span is for a normal height individual. She has a height of only 150 centimeter. So again, when you talk of these measurements, for example, the distance from upper incisor in endoscopy, it depends on the height of the person. It cannot be the same for a 150 centimeter person and a 170 centimeter person. So you have to keep the height of the individual in account when you consider these distances. Okay.
Yes.
So for her, it may be normal. And again, go
Systemic.
back, please.
Yes.
See,
Yes,
as
sir.
far as I'm concerned, if I am the examiner,
Yes.
I would accept that when you say no ascites, but still there are some examiners who insist that when you describe the examination, you should describe the findings, not your interpretation. So it is better to say that flanks are not dull.
Yes. A systemic examination, cardiovascular, respiratory, and CNS examinations were normal.
Go back to your general physical examination, please.
Yes, sir.
Are you sure her pulse is, you have examined or you got this case from somewhere?
They examined, sir.
So are you sure her pulse rate is 75? Why am I asking that?
Uh, because she had pallor and
Hmm.
these things, sir. There is history of bleed,
Okay, suppose
and
she
there is a
didn't have
pallor.
pallor, suppose she hasn't had bleed for last few months. Still, why am I asking about the pulse rate? What drugs is she on?
She is on propranolol or beta blockers, sir.
So the patient who is on propranolol, before you say that her pulse rate is normal or high, you have to be very careful that you are correct, because you expect her pulse rate to be low.
Yes,
That
sir.
is how you titrate the dose of propranolol. The target dose is that the pulse rate should get reduced by, I think, about 20 or 25% of the baseline. So I agree that here there is a mix, because she has pallor, which will cause tachycardia, and she's on propranolol, which will cause bradycardia. But what I'm trying to hint at is that you have to be very careful. Same way, patients with deep jaundice, before you say that pulse rate is normal, be very careful, because jaundice can cause bradycardia. Okay. See, these are small points, but suppose in the file the pulse rate is recorded as low and you say pulse rate is normal, examiner knows because he has gone through the file, then it gives an impression that you are casual, you haven't examined, and you are saying things which you haven't looked for. That doesn't give a correct impression. Hmm.
To summarize my clinical findings,
It's okay.
uh,
It's okay. So just summarize the important findings on examination. What are the important findings on examination?
on examination, there was a large spleen, sir, palpable
She's
massive
not
splenomegaly.
averagely built. She's short built. 150 centimeter will be described as a short built. Even for a female, 150 is not a normal height. She is a short built but well nourished. Both are different. Built is the height. Nourishment is the body weight and BMI.
Examination added with the splenomegaly, sir, large spleen. Rest of the examination was normal. And with this, my diagnosis would be portal hypertension with the symptomatic splenomegaly with status post bleeder, which was managed with endoscopic intervention.
I don't know whether it is right to say endoscopic intervention, because, as I mentioned earlier, probably she hasn't undergone the correct endoscopic management protocol. It has only been an SOS management, because if you there is a difference. A patient who has had a proper endoscopic management and still bleeding versus a patient who has had an improper endoscopic management. Because if a patient has had a complete endoscopic management protocol these days in the hands of an experienced or expert endoscopist, esophageal varices must be eradicated. It is only gastric varices or ectopic varices. So then you are more worried. On the other hand, a patient who has not received proper endoscopic management, if she is still bleeding, there is a still possibility that she can be controlled by endoscopy. Okay? So proper history of endoscopic management is very, very important. How many sessions, what intervals, if the patient knows what was the variceal status to begin with, what is the variceal status now, when was the last bleed, all these things must come out very clearly in the history, because they are going to decide what you are going to do next. And as I mentioned earlier, the clinical diagnosis should be extrahepatic portal venous obstruction.
Extrahepatic portal.
Yeah.
Yes.
Okay. So she comes to you now at this stage. What will you do?
Sir, first I'll review or investigate previous records for all the
Which record
endoscopic.
you want to see, in what order?
I would look for the hemograms, sir, which she has, and endoscopic
Is that the
reports.
most important? Has history for 15 years. She will have at least 100 hemogram reports.
So
I
recent,
I asked you a specific question: which investigations you want to see and in what order? So you have to mention the first most important investigation which you want to see.
that is the ultrasound abdomen, sir, followed by upper GI endoscopy.
Yeah, I personally would say the last upper GI endoscopy because I want to know what is her current variceal status, isn't it? Ultrasound also, I'll give it to you. It's okay. No, I have no objection. But from the overall management point of view, it is the last endoscopy report.
That's it.
Okay, let's see the ultrasound report since you want to see the ultrasound. I agree. Ultrasound will. Let's see the hemogram.
Yes,
Let's see the hemogram.
that's
Is this the current
it.
hemogram?
This is the current hemogram, sir,
Yes.
after she came to here.
Yes.
So it showed there is an anemia of hemoglobin of 7.6 with a leukocytopenia of 3,600 and thrombocytopenia of 64,000 with a normal LFT
So
with
say that
isolated
she has pancytopenia. And
pancytopenia.
in view of this, considering the history, you can also say that she has symptomatic hypersplenism because she has excessive menstrual bleed.
Yes,
So
sir.
she has pancytopenia, she has splenomegaly, and she has hypersplenism,
Hypersplenism.
symptomatic hypersplenism, not only hematological. If she didn't have that menstrual history, it would be called hematological hypersplenism, which doesn't usually become the indicator for intervention, surgical intervention. But if it is symptomatic hypersplenism, then your threshold for offering surgery in terms of splenectomy combined with a shunt becomes even lower. What else? Rest of the investigations?
Rest of the investigation were normal, sir. ALP was elevated, sir, 264, and rest were normal, sir.
Everything is normal. Albumin
Yes,
is
sir.
normal.
Sir, she had a low albumin, sir, 3 point.
Anything less than 3.5 is abnormal. You may say that my threshold for taking a patient for surgery is 3, but that is not normal. Normal has to
Yes.
be at least more than 3.5. So she has some mild hypoalbuminemia and alphos is raised, although we don't know in that lab what is the normal range. Okay, next.
Ultrasound abdomen with color Doppler, sir, which showed there is a liver is normal in size with normal echo texture, right? There is a mild central IHBRD, and there is a splenomegaly of 18.6 centimeter, and portal vein is replaced by a cavernoma.
Don't read the report. Just say what do you make out of it. We can all read it.
Yes. Uh, there is no feature suggestive of CLD, sir. However, there is a IHBRD is
So
there.
normal size liver and normal echo texture, does it rule out cirrhosis?
Uh,
It doesn't. A well compensated cirrhosis liver can look normal on an ultrasound. I don't think you can rule out cirrhosis. If it is shrunken, if it is altered echo texture, you can say it is cirrhotic. But check with your medical G or radiology colleagues. I don't think a normal looking liver on ultrasound, you can say that it is not cirrhosis. Okay. What else is important here? What are the important findings?
and the presence of cavernoma, sir.
Okay.
Uh,
So
and
which confirms you should say
which
that there is no portal vein, it is replaced by a cavernoma, which confirms my clinical diagnosis of extrahepatic portal
hyperstrophy.
venous obstruction. What else?
And the diameter of the splenic vein is important, sir. Here is 11 mm.
Yeah, you
And
can say splenic vein is 11 millimeter, which is good for me in case I'm planning a shunt. What else?
um,
There is mild central IHPRD, which correlates with your raised alkaline phosphatase.
sir,
So you would carefully look for any evidence of portal biliopathy.
yes.
And what else? If you are planning surgical
And
management,
the left renal vein diameter.
left renal vein, kidney is normal. I presume normal, they mean normal in position also. It is not
Yes, sir.
ectopic. Suppose it was an ectopic left kidney, you can't do a PSRS or a DSRS. So kidney is normal in position and left renal vein is reasonably okay. Left renal vein diameter doesn't matter because anyway you are going to use the side of the left renal vein. It is the splenic vein diameter which is more
Clinic.
important. Okay, so all these things you should on your own report. This is what you are looking for on ultrasound in a patient with portal hypertension, especially EHPVO. You should also point out what is missing here, what is not mentioned here, which you would like to know. In view of the central IHBRD raised alphas, you would like to know whether there are any pericholedocal
Any very
collaterals, although they have mentioned cavernoma, but specifically, if they could have seen that, and not in this case, but in general in portal hypertension, whether there is any ascites or not. Although clinically there was
ascites.
no ascites, but there still could be ascites. So you would like to know ascites. And as
Ascites.
my colleague in SGPGI, Dr. Richa, a pediatric surgeon who has large experience with the EHPVO, she always says that three abnormalities you can have in patients with EHPVO, especially during bleed. One is that they can develop transient ascites. Second is that they can have some derangement of INR, but that doesn't indicate liver dysfunction. And third, that when we operate upon them or on imaging, the left lateral segment is usually atrophic. This is her observation. So these patients can have transient ascites, especially during and after a massive bleed, which resolves on its own. Okay, next. Yes.
This is a previous upper G endoscopy report, sir,
Mhm.
which was done in 2020, which showed there was a large esophageal varices with there was no red color signs, and she underwent endoscopic variceal band ligation for the same. And the last endoscopy report was done at October 2024, 5 months, 6 months back, which showed there was a esophagus showing a small esophageal varices, and and there was a changes of band ligation. And impression was the small esophageal varices.
When was her last bleed?
It was in September sir, 24. That is 7 months back
So this endoscopy is done after the last bleed,
after the last visit.
and it says only small esophageal varices.
Yes.
Okay. Anything else?
Uh, I would like to plan for the surgical interventions that require imaging, that is CT portovenogram, to
Why
uh,
surgery? She has small esophageal varices. Last bleed you said was in September. Maybe she won't bleed now because there are only two columns of small varices.
but however, sir, she also developed other complication, that is symptomatic hypersplenism and symptomatic splenomegaly. That becomes indication for surgery.
So is her spleen symptomatic? The splenomegaly.
The dragging sensation is there, sir. However, she is not on any regular analgesic, but heaviness and dragging sensation.
Yeah, so this whether to call it symptomatic splenomegaly or not becomes a very subjective assessment because it depends on the patient's perception, it depends on the patient's occupation, it depends on how it is interfering with his or her daily activities and quality of life. Um, because these patients usually have this dragging sensation, heaviness. They may have early satiety, postprandial fullness. As we discussed earlier, they may have acute pain because of infarct. So it becomes a very subjective kind of assessment. But yes, in this particular case, as we discussed earlier, she has symptomatic hypersplenism because the platelet counts are low, the other counts are also low, and she has excessive menstrual bleeding. So it
Mentioned.
becomes symptomatic hypersplenism. Of course, we forgot that on the ultrasound, we should have had a mention of the uterus also, whether she has a primary cause in the uterus which is responsible for the bleeding, whether there is a fibroid which is responsible. But if it is normal, then obviously we will label it as a symptomatic hypersplenism. So you said that you want a CT photovenogram.
Yes.
Has it been done?
Yes, sir.
Is she married?
She is married, sir. She is Nali Paris.
So you want to do a CT for her?
Uh,
Can you avoid CT?
we can avoid, sir, by getting a MR photovenogram
Yeah, so in a
with
young patient, in
massive.
a female patient especially, if there is a choice and if you can get the same information, most people would prefer an MR rather than a CT. And also, uh, although not ideal, but many people would probably go ahead without imaging, because ultrasound shows that there is a 11 millimeter vein. In fact, earlier we also used to go by ultrasound, but then over a period of time we did change. So I would agree that most groups would like to have some imaging. Why do we want to have an imaging? Why can't we just rely on ultrasound? Any reason?
That is a more of a subjective findings, ultrasound. So,
Okay.
um,
What is the pitfall? What can happen in ultrasound which can get sorted out on a CT or MR photovenogram? A large collateral can look like the splenic vein. So you want to be sure, because these collaterals, although makeshift shunts are described, you can use even a large collateral for a shunt, but they are thin walled, sutures don't hold well, and these shunts don't function as well as a proper linorenal shunt. So you want to make sure that what is being interpreted on ultrasound as the splenic vein is actually the splenic vein. It is both ways. Sometimes ultrasound or Doppler doesn't show a splenic vein, but when you do a portovenogram, you see a vein because it was being misinterpreted as a collateral, or it could be the other way around. That is why most people today, I agree, would get a portovenogram done. Let's see. Devin, if you want to add anything in between.
yes, liver is showing, sir, there is a dilated uh, intrahepatic biliary duct, and there is a multiple pericholedocal, and there is a, perihilar large collateral seen, and there is a large portal vein is dilated, and there is few perisplenic collaterals also noted, sir. And there is a large spleen, that is massive splenomegaly.
Show us the course of the splenic vein. Yeah, keep tracing it. Yes, yes. And after that, so you can see a good splenic vein, and you should say that there are multiple large collaterals around the common bile duct, which is dilated. There is intrahepatic biliary radical dilatation. So see these collaterals. I think in one of the earlier sessions we have discussed, maybe in the master class, that whether in a patient with portal biliopathy, if surgery is required, can you approach the duct without doing a shunt? Look at these collaterals around the duct, and these are all
Yes, sir.
high pressure, thin walled vessels. You can't even put a needle into the common bile duct, leave alone making an incision in it without causing bleeding. So, if you try to approach the CBD in a case like this without doing a shunt, without letting these collaterals decompress, you will have massive bleeding, which you can't control during surgery, and it invariably would result in a mortality on the table because of massive bleed. Look at those collaterals around the CBD. What else you want to see on the CT?
Uh, to see the renal vein also, sir.
Yeah, so
Renal
on
vein.
in the axial cuts, you should have mentioned. Here also you can see,
Yes.
but what is the distance between the splenic vein and the left renal vein, in addition to
Renal.
the position of left renal vein, size of the left renal vein, the fact that it is there, and also very important, whether the other kidney, because one of the complications which can occur is that you have a accident and you may have to sacrifice the left kidney. Rare, but it has to be kept in mind. So you have to have a normal and normally functioning right kidney before you take up a patient for a renal shunt. So show the renal vein, left renal vein.
This is the left renal vein, sir, which is crossing the vertebra and reaching the renal hilum.
You can even see the adrenal vein. I think if you see the vein going,
Um,
yeah, from the superior
cranial.
border of the, because it is important that sometimes the lie of the adrenal vein and the size is such that you can use even the adrenal vein. And also, it is important to see the adrenal vein and the gonadal vein, because, as again we discussed in the master class, that if you believe in encircling and looping the left renal vein, then some people would electively divide the gonadal vein and the adrenal vein so that you can get a free play on the left renal vein. Then you can apply the clamp, occluding more of its circumference, and you have a good freely accessible wall of the left renal vein. Not mandatory, not everyone does it, but some people would do it, or in some cases, you may have to do it. Anything else? Go back to the
Uh,
hemogram, please. The blood investigations. So this is not CLD. Okay, yeah. So viral marker, it's just mentioned viral marker, but any patient, even if it is not CLD, who has received multiple transfusions, you have to check the
the
hepatitis and
hepatitis.
HIV status. So that's also
Yes, sir.
important. Here, it is not important from etiological point of view. It is important from your own protection point of view, and from the point of view of counseling of the spouse, if the patient is any of the viruses are present.
Yes, sir.
Okay, so what? Any other investigation you want before you operate upon her?
Uh, no, sir. Uh,
So what is your surgical plan?
Sir, plan would be proximal splenorenal shunt with the splenectomy, sir. Because that will address the hypersplenism and also it will decompress the portal hypertension. So, in a case of EHPV, PSRS with splenectomy would be the choice.
Suppose I say that she hasn't bled for last maybe 2 years, and on last endoscopy there is just one or two columns of very small grade 1 varices. Then would you do only splenectomy?
Uh, no, sir. I
Why
would
not?
still go for uh, because after splenectomy, if there is a future requirement of shunt surgery, that will not be possible, sir, because the vein would be thrombosed, and uh, so
Not
I
in
would go
all
for
cases, but you should say that once we do splenectomy, there is a high chance that the splenic vein will get thrombosed, and that thrombus may even extend into the portal vein. So splenic vein may not remain available for a future shunt. So
suggestion.
that is one reason. Any other?
Um,
Suppose this was a
uh,
patient with cirrhosis and there was symptomatic splenomegaly and hypersplenism, portal hypertension and varices are controlled endoscopically, and then you are doing splenectomy. Is there a difference in the management?
for cirrhotic patients, sir.
Cirrhotic, compensated cirrhosis, varices have been controlled, there is no GI bleed, but patient has symptomatic splenomegaly and hypersplenism,
Then
and you are planning to do a splenectomy.
that we can do for splenectomy alone, sir. if varice is controlled by endoscopic management,
There also, you
because
would not do splenectomy alone. You will combine it with devascularization. The what I was trying to get you to is that in a patient with cirrhosis, and now the All India Institute group says even in NCPF, prophylactic shunt is not to be done because it has high chance of risk of encephalopathy. On the other hand, in EHPVO, since the liver is normal, liver function is normal, with a patent shunt also, there is very little chance that patient will develop encephalopathy, and that is why even if it is not otherwise indicated, if you are going in for a splenectomy alone, which could be symptomatic splenomegaly, symptomatic hypersplenism, some people say even for growth retardation, then when you are doing a splenectomy, if you are sure that it is EHPVO, it's not CLD or NCPF, then most people will add a shunt at the same time, which you would not do in a cirrhotic and which you would probably not do in an NCPF also. NCPF earlier, the AIIMS group led by Dr. Piyush Sani used to say that in NCPF prophylactic shunt may be done, but then when they followed these patients, they found significant clinical encephalopathy in about 10 to 15% of cases, and now they have stopped recommending prophylactic shunt. And when we say prophylaxis, it means that the indication for shunt is not bleeding. Patient may have bled earlier, but the bleeding has been controlled by endoscopy. You are going in only for the spleen. So in that case, you will do splenectomy and you will add devascularization to take care of any gastric varices if they are there. But in EHPVO, hardly ever you would do splenectomy alone. You would almost always combine it with a shunt, unless, of course, there is no shuntable vein. The other thing which you should say that there are subtle hints here, looking at the size of the pericholedochal collaterals, looking at mildly elevated alphos, central IHBRD, that this patient is developing portal biliopathy, which is going to evolve over a period of time. So even if bleeding is not the indication, to take care of the portal biliopathy, to decompress those collaterals, you would like to add a shunt. So suppose she gets admitted today, you will do the shunt tomorrow?
no, sir. First, I'll arrange the blood and blood products, sir, and I'll optimize the hemoglobin to at least 9 or 10, and then I'll take up for surgery.
Any other preparation?
Vaccination for splenectomy, sir.
So that again is a
2 weeks.
debatable topic. The All India Institute group doesn't believe in vaccination and prophylactic antibiotics, but the HCPG-IMS group did believe. So when do you vaccinate? What do you vaccinate against?
We'll vaccinate at least 2 weeks prior to surgery, sir. Vaccination against Haemophilus influenza, pneumococcal vaccine, and then meningococcals.
Yes, so triple capsulated organisms, and preferably at least 2 weeks, because that is the minimum time required for good immunity to develop. So vaccination, arrangement of blood and blood products. Okay, during surgery, uh, suppose there is excessive bleed because of pancytopenia, because of thrombocytopenia.
Yes, sir. Um, I'll transfuse the platelets after ligation of the splenic artery. And
Yeah, so your answer should be that yes, I expect little extra or excessive ooze during the incision, but I will try to control that with pressure, with cautery or whatever. Quickly, I will get into the lesser sac, open the lesser sac, look for the splenic artery, loop it around, and then ligate it, and then I will ask or request my anesthetist to give platelets, because before that, if I give, then they may immediately get destroyed in the enlarged spleen. So ideal time to transfuse any of the blood products is as soon as or immediately after you have had the control of the splenic artery. That is one step which you should always take. Okay, so if you want to discuss the operative part also, then as I have been telling other students that please contact Dr. Anand, say that you would like to present the surgical part of portal hypertension, the various types of surgical procedures, indications, contraindications, and then if time permits, we can even discuss the technique. So he will give you a slot when you can
Yes, sir.
prepare and you can present this. Okay.
Okay, sir.
Any of the faculty online, any of the students would like to say or ask anything? Dr. Banerjee, see you there. Good morning. Ajay, you are there? Dr. Ajay? Or is it some other Dr. Ajay?
Sir, good morning. I'm there, sir, Dr. Banerjee.
Yeah. You want to say or add anything to the discussion?
No, I just wanted to add one more thing, that one of the indication for doing a shunt, even if will be for the failure to thrive or growth retardation.
Yes. So in a child or adolescent, teenage who has not reached the peak
Yeah.
of growth, many pediatric gastroenterologists, they believe that surgical intervention can provide them growth spurt. Whether it is splenectomy or whether it is shunt, that we don't know. But as I said, that in EHPO you would almost always add a shunt.
So even if bleeding is not the indication,
Yes.
they even indicate a prophylactic shunt in these cases for these reasons.
Yes. So growth retardation also may be considered as a soft indication for surgical management. Yes. Okay, Dr. Vinay. Thank you. Thank you very much. We
Thank
will
you, sir.
close this session.
Yes.
Thank you.
Thank you.